So, good evening, everybody. We are live now, and I'll hand it over to Dr. Shivshankar for further proceedings. Over to you, sir.
Thank you, Dr. Ashok. Friends, we have today a challenging webinar because of the challenging times we have and the whole world is passing through. The COVID pandemic has really changed the way we have been practicing. And I was told yesterday itself the England or the UK has again gone in for a second lockdown for 28 days. So that shows that the pandemic is not going to end so quickly, and the second wave or probably the third wave is also going to come, and we should be all prepared for this. To speak more about how to restart our elective orthopedic procedures, both trauma and orthopedic procedures, we have Professor David Johnson today. He's a consultant orthopedic surgeon at Stepping Hill Hospital, Stockport, NHS Foundation Trust at Stockport. We also have President of Indian Orthopaedic Association, Professor Dr. R.C. Meena from Jaipur. We also have Dr. Professor Sandeep Kumar, Professor at Hamdard Medical College in Delhi. He is the Secretary of Indian Orthopaedic Association. We have Dr. Babulkar from central part of India, that is Nagpur, who has been doing a lot of work, and his whole hospital has been converted into a COVID center, and he has a lot of innovative works which he has done. Dr. Rajendra Chandak, a private practitioner, again from central part of India, that is Nagpur. We have Professor Dr. Adul Patil, who heads the trauma unit of Sancheti Hospital of Sancheti Institute of Orthopedic and Rehabilitation. So we have so many big wigs today here to discuss about how to go about and how to start the practice. If you have any questions, all of you might have my mobile number. You can WhatsApp me your questions. I will ask the speaker about your doubts. And also, if you are watching on OrthoTV or YouTube, you can punch in your questions in the scroll box there that Dr. Ashok Sham will coordinate with me. We also have Dr. M.K. Shashidhara. He is an anesthetist at Birmingham. Incidentally, he's my classmate, and he was the one who helped me to rope in Dr. David Johnson today for our wonderful webinar. To introduce today's speaker, Mr. Professor David Johnson. Mr. David Johnson has been a consultant orthopedic surgeon since 2001 and has a practice exclusively within the knee surgery at NHS practice based at Stepping Hill Hospital, Stockport. David graduated from St. Andrews, then Manchester University. His orthopedic training was undertaken within the Northwest, that is the Manchester region, where he undertook a fellowship in knee surgery. He also graduated with a Master in Philosophy of degree from Salford University following research into the outcomes of knee surgery. His research and audit interests are varied, being mostly centered on the outcomes of knee surgery. He has made many presentations and publications of his work. This work is ongoing, and he continues to supervise the research program within the orthopedic department at Stepping Hill Hospital. He also acts as a reviewer for articles submitted to the Bone and Joint Journal, the Knee and Cochrane database, as well as reviewing applications to the National Institute of Health Research. He is a joint clinical lead at MAHSC Inflammation and Repair Domain and current chair of the Greater Manchester Orthopaedic Alliance. He has been the specialist trainee teaching program coordinator and support trainee research coordinator. He also leads an active research unit and supervises on the knee fellowship training scheme. He is a member of British Orthopaedic Association, the British Association for Surgery of the Knee, and British Orthopaedic Research Society. With this brief introduction, I would like to invite Professor Dr. R.C. Meena from Jaipur. He heads the orthopedic department at one of the largest medical college in India, that is SMS Medical College. Incidentally, Jaipur was the one which faced the brunt of COVID for the first time in India. So probably he has the maximum experience of having seen and treated both clinically, medically, as well as bureaucratically the COVID. So I invite Professor Dr. R.C. Meena to say a few words before we start the program. You have to unmute, sir. Sir, you have to unmute.
Hello.
Yes.
Yes, sir. Thank you, Seva, giving me this chance. So, good evening to dignitary of the IOA, Dr. Shiv Shankar, President-elect, Dr. Sandeep, current Secretary, Dr. Shyam, the technical person of this TV, Dr. Sasidhar, Dr. Sasrat, Dr. our special guest and speaker, Dr. David Johnson from the UK. Friends, really this is a very challenging time. And we are facing day-to-day problem in this unforeseen period of this COVID-19 actually. You would not believe, but daily 2 or 3 my either resident or my staff or my female paramedical staff get infected when they are practicing. Department of the SMS is definitely one of biggest, who having the 37 postgraduate admission, 300 exclusive bed for the orthopedic and separate Institute of Orthopedic and Traumatology. And regarding the corona cases and COVID cases, we have a separate hospital of the government, that is the Rajasthan University Hospital of 1000 bedded with 600 ICU. That is the again one of the largest center of the India, I think so. And a full team work there. Even that our resident doctors of the orthopedic go to serve the COVID patients by rotation and by the routine duties. But the topic of today is very important in this type of crucial period and challenging practicing scenario, that how do we start the practice and elective surgery procedures in this challenging period has been well taken, chosen by Dr. Seva for our benefit, for the benefit of the fraternity and our orthopedic surgeons. I must congratulate him. I must congratulate Dr. David Johnson, who has been accepted our invitation on behalf of IOA and Dr. Shiv Shankar to deliver this prestigious talk during this meeting. And I am sure that the members and delegates, those who are on the screen across the country and abroad as well, will definitely benefited with this prestigious talk. I wish you all the best and take care, all of you, from this COVID unforeseen, and your family. Stay healthy and safe. Jai Hind, Jai IOA. Thank you once again, Shiva.
Thank you very much, sir. Professor David Johnson, sir. So my plan is that we'll discuss for 5 minutes what is the scenario in India, so that you'll get an idea about our problem here. I'll first ask Sushrut Babulkar, because he runs about 200 bed hospital, and which has been totally converted into COVID center. He was sleeping for more than 1 month within the hospital premises because he has aged parents at home. So let me ask Sushrut, what are the things, how the COVID has changed his practice?
So let me start with thanking and welcoming David Johnson. Hi, David. Our connection is briefly, I worked as an SR in Hope when I was there during MCH, and Mr. Adams was there. And of course, Jonathan Noble was my mentor at that time. Thanks, Shiva. Thanks for inviting. So when the country started with this COVID, it started from the north belt. So Jaipur, Delhi got affected. It came down to Mumbai, which is the western part of the country, and then it migrated to Nagpur. So we knew this wave is going to come, so we could kind of gauge the impact of it, the flow of it. So we were kind of ready to face it. The readiness was by government institution as well as private institutions. Government put in huge hospitals, and private institutions were alarmed and kept ready. The day Nagpur, that's my city in center of India, was hit by COVID, within 3 to 4 days, all government institutions just crumbled down. They just could not handle the load. People had no belief in the government system in India, unfortunately, and they started rushing to private hospitals. Initially, multi-specialty private hospitals were converted into COVID in the first wave, which lasted for 3 4 days, and immediately fifth day specialty hospitals like mine, which is a purely orthopedic hospital, was also requested by the bureaucrats and politicians to help the society out in converting into COVID. And as Shiva knows, I had read about COVID. We had set the guidelines for the entire country for COVID. I was instrumental in that. Uh, a month earlier than I had to actually jump into COVID scene. There was a time in India, in my hospital in Nagpur, that outside the hospital there are 25 people panting, gasping, wanting ventilator, waiting outside. It was a bad scene for a week. I had to shift myself from my house uh, to the hospital for those 6 weeks period because I had elderly parents at home. I didn't want to contaminate them. So I stayed here. So my staff also decided to stay here, which formed a role model for the entire state again to work on. So if the chief stays there, the entire praja or the entire battalion would follow the captain of the ship. So the staff also, without any extra money, without any extra wages, supported me. That's the general part of COVID in India. What happened in orthopedics? So the moment it got hit at Delhi, in Mumbai, Nagpur elective surgery, because it's the same state, was stopped, and all the elective surgeries by bureaucrats was stopped, by patients was stopped. So elective surgeries went down to zero. What happened to trauma surgeries? The hip fractures predominantly kept on coming. We had to prepare ourselves. So it was patient care and it was staff care, and it was completely a dart thrown in the dark what we were looking at. Of course, we were following the OTA guidelines, and in June, already the JBGS had come up with all those supplement online, which supported us because we were much later affected than UK. June, I think JBGS was already out in the third week of June, which gave us some guidelines to follow in terms of trauma surgery in orthopedics. Was it vastly different? We agree with the data which was produced by, I think, University College London, which suggested that asymptomatic COVID negative patients would have the similar complication rate as otherwise means control group. So we had the similar experience in our patients. Of course, we took precautions that we would do their pre-testing. We would prepare the staff completely not to contaminate themselves, and we would decrease, and that was probably Chinese thinking, decrease the aerosol. So we would not use cautery, we would not use reaming or minimum reaming, and we would change some part of surgery which was more aggressive. For example, intra-articular fractures, we would probably do minimal internal fixation and wait, hopefully, to look at 3 months ahead of time. So that's how we changed the kind of surgery. That's how we changed the pattern of patients to be looked after, and our care. Anesthesia was the same. Anesthesia was no different. So that's
Mechanism of surgery.
happened.
Thank you, Sushant. I would like Sandeep Kumar. He was instrumental in forming the guideline for Indian Orthopedic Association. Just you can add few lines what Sushant might have missed.
Yeah, thank you, sir. First of all, I'll thank Dr. Shiva, sir, for giving me an opportunity to come on this platform and discuss few of the things. I'm very happy that we were the among the few to give the IOA guidelines along with the IOA officials. And I'm happy to announce that it was on 14th of April that first guidelines from our association came out on the basis of whatever papers we got from China and France and UK at that point of time. And as Dr. Shushruth has said rightly, Delhi was hit the foremost, and the government immediately stopped all the elective surgeries. The reason behind was we wanted to reserve our resources so that whenever these sort of patients will come, we have to take care of them rather than doing the elective surgeries. But yes, patients kept on coming and coming. So those patients, we strictly followed those patients in which for 6 weeks, there was not much of a difference whether we operate or we manage them conservatively. We started managing them conservatively. But yes, as there was initial papers that hip fractures should be operated, we kept on doing, but there was a separate isolation ward. We would use to do RT-PCR and everything. And we have to be very careful. We made teams accordingly, team 1, team 2, and those who were presented in the COVID, they were used to be given a quarantine period so that others should not be affected. So I think in at least in Delhi, the government really worked hard and we could manage because it's the foremost place where it was hit and we could manage. Most of the government hospitals were totally converted into COVID hospitals. But yes, if on ground level, if I analyze now, then definitely patients had a lot of problems. We are having a lot of backlogs with us at present. May it be an elective surgery like arthroplasty or an arthroscopy, but other than that, even the trauma got neglected. So country like India, where there is so much of a trauma, so we are really struggling hard. So I think I would like to discuss with Dr. David Johnson that how these should be managed now in this era. Thank you.
Okay, just any few words from Dr. Adul Patil about any changes you had done in your OT or your orthopedic practice which for the COVID. What surgeries you are doing last year compared to at present what you are doing? Yes.
It is 1/4 of what I am doing last year currently. And I am from Pune, which was the hotspot of entire India. At one given point from Pune, there were 5,900 patients in one day positive. So it was the biggest positive rate in entire India. So we are having, and we had the first hit on July, August, and September, where our completely orthopedic setup was converted to almost 50-bedded purely COVID center, which was having a COVID general admissions, not orthopedic admissions. They were purely COVID hospital. They were having an ICU, they were having an isolation ward, they were having a HDU. So depending on that, we had to treat general COVID patients. Our elective work gone down completely, as Sushruth said, because it was a bureaucrat which said that no elective work. Trauma kept on coming. So we have divided our trauma into emergent and urgent and elective. So emergency means like a crush injury or a vascular injury. Then that we have to take. Emergent like urgent like hip fractures or shaft femur fracture, where the next day we used to take these patients. Again, when it was like a fracture shaft femur or a hip fracture, we used to classify symptomatic or asymptomatic. Asymptomatic patients which willing to take risk, we used to operate. And those patients which are having symptomatic patients, which were transferred to a COVID ward till his all viral parameters are stable, then it was treated non-operatively and then operatively. And elective, right now, what we are doing is doing RT-PCR, complete workup, and then started gradual elective work.
Okay, thank you. I think with this brief introduction about what we are facing now, I'll ask David to take it further through his talk. Please, okay. David.
Thank you. Right, I'll just get loaded up. Where's it gone? Where's it gone? There we go. Let's try again. Okay, so hopefully you can see that.
Yeah.
Yeah, good. So thank you very much for asking me to come and speak to the group. I feel very privileged to be invited to join in this very large group and offer what I can to help. My talk is very much based on our local experiences, both within Greater Manchester and at Stockport. And a lot of what I've heard already mirrors very much what we've been through in our own area. So we'll come to that in a moment, but I think hopefully I'll cover some things which will be of use to people. It is very much an overview. There's an awful lot I could talk about. I've been involved in lots of the policy formation within our hospital and feeding some of that into the British Orthopaedic Association that we can discuss if there are any questions that arise, and I'm quite happy to take questions. I will flag up a few areas of questions through my talk, and we'll field any from the panel as we go along, rather than all at the end. It'll break the talk up a little bit. So before I go on, I'd like to thank a couple of people. Phil Turner, who's a previous president of the British Orthopaedic Association, and Andrew Tunnicliffe, one of our managers at Stockport, who produced some of the material for this talk. And certainly with Phil, there's been a lot of work that I've done with him. He's been guiding national policy with regards to orthopaedic return to activity, and also various other policies around protection, what cases we should be doing, prioritisation and so on, both for the BOA and for NHS England as well, and Public Health England. So I'm representing the Stockport NHS Foundation Trust, which is my hospital, or Stepping Hill Hospital, and the Greater Manchester Orthopaedic Alliance, which I'll introduce to you in a moment. So welcome from Stockport. It's a lovely sunny day. It's about 10 degrees at the moment. We're just coming into winter at the moment, which carries its own issues aside from COVID. Just to give you an idea where we are, we're just on the south side of Manchester, which has a population of around 3 million. When I was asked to give the talk, I did wonder what relevance our trust within our area would actually have to the hospitals across India. There's us on the left there. Some of you may recognise Wrightington next, the specialist hospital in the region for orthopaedics. We've got Salford Royal, which is now a major trauma centre, along with Manchester Royal Infirmary. And then we have our one of our private hospitals on the right, and we have a number of other hospitals in the region, which again I'll come to in a minute. So I was fortunate during my training to be able to go and visit a couple of places in India, Manipal Hospital in Bangalore and the Christian Medical College in Vellore. And thinking back to those times, although how the care is organised and it's funded, actually we're all facing exactly the same problems, which is a huge impact of something out of our control, which affects our practice. And our practice, I think, no matter how it's organised, is effectively the same. And so hopefully a lot of what I'll cover will be applicable to any hospital in any country, not just in our region, in our country. So I'm going to briefly cover who we are, who I am. You've heard a little bit already, the GMOA and about Stockport, what the effects were of COVID in GM, the challenges that we're going to have restarting elective work, what we can do to reduce risk for patients and staff, and then the main bits around making it actually work, and looking at 4 areas which I'll come to, and just some thoughts of my learning so far as to how we take things forward from here. My original talk was going to be on restarting elective work after the pandemic. I've changed that to restarting elective work during the pandemic, because there's absolutely no doubt that this is going to be around for a good while yet. As I talk, you may hear me muddle up different terms: COVID-free zone, green zone, safe zone, restricted zone. As far as my feeling is, they're all the same thing, and I hope I don't cause any confusion. We've renamed these zones several times over, so please forgive me if I call them different things, but they are all the same thing, and I'll come to their importance in a little while. So as you've heard, I'm a consultant orthopaedic surgeon. Knees is my thing, but I undertake, like the rest of my colleagues, general trauma. Outcomes of knee surgery is my particular interest, which is where I held my chair at the University of Salford. But I also hold a senior lecturer's position at the University of Manchester for my lead in the Greater Manchester Orthopaedic Alliance. I'm very interested in the use of data. I was previously the Basque webmaster and the coding lead as well. The Greater Manchester Orthopaedic Alliance, I think, is what merits some mention, because it has been helpful in looking at how we're restarting activity amongst lots of other things that we do. I'm sure you've all heard of the Getting It Right First Time programme led by Tim Briggs down at Stanmore, who looked at trying to reduce variation between trusts on outcomes of surgery and practices. And he went around the country at that time speaking to each trust. He went to every single trust in the country, had 200 odd visits. But Phil Turner at that time thought that this was a daft idea, and wouldn't it be better for Tim to come to Manchester and speak to all of us all at the same time and put up the charts of how we were doing compared to each other. And he did that. He produced charts with, at the time, I think it was 10 trusts involved in the meeting, labelled 1 to 10. And we spent the first 20 minutes trying to work out who 1 to 10 were, and it wasn't too hard to do. So we decided that we would create a group that would actually share this information. We all know how we're all doing compared to each other, and we've all agreed that some areas there are common themes that we can improve practice on. We're now supported by Health Innovation Manchester. If you want to know about them, just do a search on Google for them. They're a very interesting organisation who are doing good things across the whole of the conurbation of Manchester. And within that, we have the Manchester Academic Health Science Centre, MASC, which links the university with clinical practice. I think somebody's got their microphone on. Hopefully that's it. Yeah, so Manchester Academic Health Science Centre. And we're tasked with trying to help bring research out from the university into clinical practice. In particular, the COVID, we have something like 13 or 14 different major trials going on at the moment that are being brought straight out into practice around testing, genomics, proteomics, and so on, which are now being taken up by the National Institute for Health Research. So there's a lot of work that's been diverted very quickly into those projects. The one big thing that was agreed was our chief executives agreed that we were going to share data, and that has been fantastic with regard to working together within the city. So a population of 3 million, as I've said, these are the 6 trusts, of which there are many hospitals within those trusts, about 12, 13 hospitals. And we aim to organise orthopaedic surgery in an efficient and effective way. It's led by clinicians and managers locally to improve the care of the orthopaedic patient in Greater Manchester. We're analysing our results to reduce variation. We're sharing best practice. We aim to raise standards, raise the academic profile, improve training, and as a result of all this, reduce costs. Now, you may ask why I've brought this introduction in. It's been no different during the pandemic. We have been working together to find out what's going on where, how we can help each other through this time. So one thing to take away from this is, I know there's a lot of standalone units working across India, is if there's any collaboration you can forge that you may not already have. I know it's difficult when you're working with private practice, but any collaborations you can work with each other, you will actually help each other and benefit both organisations or several organisations at the same time. As far as my own trust is concerned, we're a single site district general hospital. We're a designated trauma unit. We're not a major trauma unit. We're a trauma unit. We'll take and triage patients and send them on to the major trauma unit if appropriate. We cover most specialties either locally within our own trust. We're particularly strong within urology, trauma and orthopaedics, including paediatrics. We've also got a very good stroke unit. And then we operate some services through a hub and spoke mechanism run from other trusts nearby. We have 13.5 elective theatres a day, 5 of which are for trauma and orthopaedics, the remainder are for emergencies. We do now about 900 joint replacements a year, mostly hips and knees, and about 400 hip fractures a year. So for GM delivery of care, we provide a significant, but not maybe the biggest contribution, but we are one of the bigger partners within the city. So I'm going to look at the effects of COVID as we came into the pandemic across GM and at the trust. And at the time, we had a single, this is very much around the, based around the facilities we had within theatre and the effect on operating capacity, and focusing it now more towards getting elective work going again, but the beds are just as important. We had a single operating theatre complex, 15 theatres, mix of elective and non-elective, 11 laminar flow, 2 laser theatres, principally for urology, and 5 changing rooms. We'll come to the importance of changing rooms a little bit later. Coronavirus came along, and immediately our theatres were converted to intensive care. We went from an 8-bedded intensive care unit, and I think we could have taken up to 60 patients, which is no mean feat from our ICU team, to convert those spaces in a really very little time, to be able to take a large number of patients. At the height of the pandemic in April, I think we had about 60% capacity filled. So we did have space. We had much more of a pressure on our beds in the general wards than we did in intensive care. As a result of this, our scrub and anaesthetic staff went to ICU, our house officers went to the medical wards, some of our core trainees and consultants went to intensive care. We certainly lost 2 of our consultants who became intensive care physicians for 8 weeks. The consultants at our level then provided the ward cover for the doctors that we'd lost on the ward. The core trainee and specialist trainee rota became one rota. They worked together at one level, with a consultant on call from home. The pre-op staff went to theatre and intensive care. We had a number of staff off shielding, both medical and nursing staff. And we already came into this with a number of pre-existing staff vacancies, which didn't help. So as a result of that, all our elective operating stopped. Our elective wards took up COVID patients, and face-to-face outpatient activity stopped as well. That left us at the end of it with 4 theatres for trauma, CPOD, endoscopy, ECT and caesarean sections. It covered everything. We had a marked reduction in staffing to staff those theatres, and the processes made the whole thing very inefficient, I think, across the country, and we found the same, that cases were taking 60% longer when we first started. Initially, we had protocols for COVID and non-COVID patients, and then we realised you couldn't assume somebody was had not got COVID. So we formed a new system of risk assessment based on testing and by the procedures that were being performed. And like yourselves, we changed how we were working. We used diathermy, which was vented, and so on. Actually, we've made a much more move back to normal practices now, which I'll come to in a little bit. And then we started thinking in around about April, what are we going to do about these problems? What are we going to do about our cancer cases, especially for urology and general surgery, urgent cases for everybody that were piling up? How do we deliver volume and for the non-urgent cases, bearing in mind a second wave was going to come along? So what was happening in Greater Manchester? That was us at Stockport. Everywhere was affected exactly the same. We had various Zoom meetings to discuss what was happening, how we were managing. Some trusts came up with some brilliant ideas that all of us have taken on. Even the specialist hospitals were affected. They had an influx of post-COVID patients going onto their wards, so they stopped work. And even if they had been kept, as Wrightington had been kept as completely COVID-free, they couldn't run the service because all their anaesthetists had gone by to their neighbouring hospital to run the intensive care unit there. So I don't know if the panel have got any questions so far. If there are, I'll happily take them now. Otherwise, I'll carry on.
Yeah. Anybody has any question to David, we can ask now. You said you all had, all the 11 operation theatres had laminar airflow. Did you do anything with the laminar airflow? Or you just converted them into ICU to have the COVID patients? Or how did you manage your other operative theatres?
So that's a different talk, but I'll touch on that in a little bit actually. But the most of our theatres are laminar flow, not quite all of them. When we switched to COVID and the emergencies, all the theatres that we had for operating in were laminar flow. Some of the non-laminar flow theatres that we have, which were a few of them, and I would thank one of our managers about 8-9 years ago, who, when we were building our new block, said, do we need all these theatres laminar flow? Would it be a good idea to make them all laminar flow? just in case we might need the capacity. And that thought 8 years ago has come to fruition in that we have got a lot more flexibility now than we would have done had we had only orthopaedic theatres laminar flow. So we were very fortunate from a decision made a long time ago to make life easy for us. So for the operating at the peak of our pandemic, it was all laminar flow theatres became storerooms for the intensive care equipment that was required. As far as what happened in the theatres, we did not change our airflow within it. There are a few good resources from Porton down on how to manage airflow, but the one big message that came out to us was don't muck about with the airflow in your theatres unless you really know what you're doing. There is a danger of actually making matters worse, and certainly there's a danger of actually increasing your infection rate by changing your airflow to try and protect the staff. And I think there are good ways of protecting the staff with a simple laminar flow system, with good use of PPE, appropriate use of PPE. And the other thing, if you're dealing with a COVID positive patient, is to make sure that you're doffing in a negative pressure area. And we had all those already set up. So we looked at our laminar flow. We thought, do we need to change how the air flows in the theatre? We didn't change a single thing. We just changed which theatres we were using.
Okay. Any other question? Anybody? Rajendra, Atul, or Sandeep? All are muted. Okay. I don't think.
I think we can continue, sir.
Yes.
Okay. So
Yes,
we're going
David.
to look at the challenges to restarting elective work now. So across Greater Manchester, there's a board that sits to look at a variety of different activity across Manchester, and they've looked at the restart problem across the whole city of all specialties. It's no small feat looking after a population of 3 million for everything. The big priorities that were picked up was cancer diagnosis, cancer treatment. Endoscopy was a major problem simply because of the high volume of patients that required endoscopy, and the fact that certainly for upper GI endoscopy that this is an aerosol generating procedure. And ophthalmology, again, it's the volume of patients was the problem there. We then had to deal with the reduced capacity both across the whole system and locally. So there was have been explored the use of the independent sector, using the private hospitals locally, of which there are a number, and using dedicated safe sites. There was an exploration of whether we can switch some of our areas to safe operating areas with no COVID patients or emergency patients. This is bearing in mind the emergencies and trauma were coming in, and at that time, this was around about April, May time, we knew there was going to be a second wave of some sort of some point in the future, but determining when this was going to be almost impossible looking back at previous pandemics. Our local challenges, exactly the same as Greater Manchester. We wanted to deliver, we wanted to help Greater Manchester. So we explored using the independent sector, which we are currently doing at the moment. I did a list yesterday, elective list, all day list there of routine arthroscopies, no problem at all. And using other safe sites as proposed by Greater Manchester. We've had a detailed look at the specialty waiting lists. I'll touch on those a bit later, but that is, again, a talk in its own right. There's a lot of work gone on into how to manage the waiting list. We also need to look at where we could deliver the capacity, other than the independent sector or other sites, how we could deliver it within our own hospital. Again, bearing in mind a second wave and the fact that whatever practices we'd put in for the pandemic, for PPE and so on, those practices are going to be changed, I think, for a minimum of probably 2 years. So reducing the risk. So before we get on to how to do stuff is firstly to take a look at what the problem is. So what are the risks? The risks are of the patient having COVID at the time of surgery. There's no doubt that that is a bad thing. There's the risk of the patient catching COVID post-operatively, either from other patients or from members of staff. And there's the risk of staff catching COVID from patients or other members of staff. And there are other risks, but that boils it down into the majority of areas. So a paper came out fairly early on in the pandemic from the COVID Surge Collaborative in the Lancet. I'm sure many of you have read this, 1,000 patients. And for those patients who were COVID positive at the time or after surgery, there was a 19% mortality rate for elective surgery. It was a little bit higher for emergency surgery, but not much. Now, there were loads of flaws in this paper, but you couldn't ignore it. And so we felt that really one big thing was to try and avoid the patient being COVID positive at the time they had their operation. There's a paper out just this month in the BJJ, 1,500 patients, and they've looked at the elective restart and what's going on between emergencies and electives. And if you're COVID positive at the time of your operation, you've got an increased mortality risk of 1.89%, but it's 17 times greater for urgent cases. And there's a whole variety and rafts of reasons this might be, in that how you handle the patients both before they come in for the surgery and what happens following surgery is different between those two groups, and a lot of it you cannot factor in. The other thing which is interesting in the paper is they looked at the risk of catching COVID post-operatively compared to the elective. So the elective is the reference group. Hip fractures are about 4.5 times more likely to catch COVID post-operatively, and periprosthetic fractures 14.7 times more likely to catch COVID following an admission. And I'm sure this relates round to how patients are cohorted within the hospital and how long they stay for as well. And one area I've not looked into in this talk, which I think does bear mentioning, was touched on in the introduction, is practices. We've changed our practices, trying to go for non-operative treatment. But the question arises, if you keep somebody in our hospital longer because you're managing them non-operatively, are they more likely to catch COVID and then die from that than if you get on and fix their hip fracture, get them mobile and get them out? So our move now is very much towards treating patients well, treating patients properly. If they have COVID and you have to do their operation as you would do normally for the hip fractures and periprosthetic fractures and so on, then we are doing that unless they are so unwell that they're unfit to have that operation. The other thing is that we're gearing up very much is to try and get back to enhanced recovery, certainly with the hip fractures, to get patients mobile and home as quickly as possible. There's no doubt that reduces their risks as well. So personal risk reduction, you've got the patient coming in and having their operation. You can reduce their risk of having COVID at the time they have their operation by isolating 14 or up to 14 days, we'll come to that in a moment, and testing 3 days and isolating certainly after that beforehand. But you want to protect the staff as well, and that is done with a combination of use of laminar flow, and I think laminar flow plays a huge part in protection of staff, along with use of appropriate PPE for those staff. And probably the biggest risk for staff actually of catching COVID is from another member of staff in the coffee room than it is in the operating theatre with a laminar flow on and the appropriate PPE being used. You then have to think about what happens after the operation. The patient goes back to the ward and there's a risk there of patients catching COVID from each other, from staff, and staff to staff transfer. And this is where your PPE comes in, keeping your distance, wearing your mask, washing hands and all the rest of it. The usual infection prevention measures are really, really important. But if in that area you don't have anybody with COVID, you can't catch it. So the other aspect to this is trying to reduce the incidence of COVID in the area that you're looking after these patients. And this doesn't matter whether this is the elective patient or a trauma patient. So in order to work out what to do about the prevalence in your area, in your hospital, you need to know what's going on in your community locally. We get these charts, they're produced once a week. There's a bit of a lag before them coming out. This is the latest one, which was produced on the 23rd of October. There'll be another one out on Sunday. And you can see this is our second spike coming along for infections across the UK. That's still not good enough. You need to look at what's happening locally. So compared to England, the Northwest, especially Liverpool, has got a much higher rate at the moment. And we tend to take a worst case scenario. So I tend to work with the worst 95% confidence interval to work out what the current prevalence rate, which is around about, as you can see from the chart there, around at about 2.5% at the moment. So your starting point is to know your local population prevalence rate. Once you've done that, you can then start to work out the effect of reducing that prevalence rate in a safe area within your hospital. And I can recommend this article by Watson and BMJ produced earlier in the year, which has a link to a really good calculator so you can work out your risk in your hospital. So at the moment, for the patients in the Northwest, 1 in 40 patients will be positive. If we test them at 3 days and isolate from that point in time, that goes down to 1 in 123 patients. If we isolate them for 14 days as well, that gets the risk down to 1 in 2,500, which to my books is pretty low. Over the summer in around about July and August, that rate was about 1 in 50,000. So we felt that at that time, if we could cohort these patients into a safe area, then the risks would be much lower, the risk of transmission amongst each other much lower, as well as having it safe for the patient on the day of surgery. We could return to normal practices, providing you don't muddle your patients up within the hospital. As a result, the requirements and reliance on PPE and appropriate infection prevention measures would reduce as you do this screening process. So does having a safe zone work? So you've got 2 choices really. You can either have a whole safe hospital. We're aiming for a couple of those. We'll come to those in a minute within Manchester. Or you can have a zone within the hospital where there is no mixing of your patients. And that really does mean you come into the building through a separate entrance. You go to a ward, which is separate. You go to theatre, which is separate. And then you go back to that ward and you leave the hospital through that same entrance you came in through, not mixing with the other areas of the hospital, the amber areas and so on. The alternative is to have a green ward and a green theatre within the hospital, but amongst normal resources, where you may go down common corridors, you may use X-ray will be the same, or you may just put the patients in together with each other, but having screened them beforehand. The COVID Surge Cancer project, which is part of the COVID Surge Collaborative, you may not have read this one because we certainly have much less to do with cancer, thankfully, within orthopaedics. This is worth a read. So they looked at all the cancer patients coming in, both as emergencies and as elective patients for cancer treatment, and 9,000 patients, and they looked at a restricted zone versus normal care. And so it's on that model, and the model was either a whole restricted hospital or a zone within that hospital versus no zoning. The risk-adjusted pulmonary complications would double in normal care, and COVID infection post-operatively was 50% higher if you didn't treat your patients within a zone. I think ring-fence zones, based on this and a number of other papers, definitely reduces risk, and if we're going forward for elective activity, I think it is well worth it. So what's our current practice? At the moment, we test and isolate every single patient from 3 days. However, and this is Public Health England guidance, you can increase that to 14 days. You can either say it's recommended, which I do for all my patients. If they can, I ask them to. But for some patients, I insist on it. For those who are immunocompromised, rheumatoid arthritis patients who may be on steroids, diabetics, and so on, we can suggest that it's mandatory for those patients. And it may be based on the procedure, it's major surgery, cancer surgery, and so on, past medical history, and certain demographic factors. Certainly, if a patient's over the age of 70, I would insist on it. Certain BAME communities, whereas patients who are, say, coming in for an arthroscopy, have no comorbidities and are under the age of 30, I'm quite happy with the 3 days isolation. Admit them to restricted surgical zone, and then enforce good infection prevention policies within that zone and within theatre when they come to theatre. And I think that is the way forward and the thing to take away from it. So as far as the risk side of it, are there any questions there?
David? Not about the risk. You earlier said that in a COVID positive patient, the mortality rate is 1.89% times, 1.89 times. But whereas in an emergency or urgent case, it's 17.1. How do you explain this? Because it's both the patients are similar, but why in an emergency situation the mortality increases so much?
Yeah, so if you look at the paper, they list a number of different procedures. And there's a huge variation in the mortality risk depending on which procedure they're having. And I rather suspect it's partly the procedure. So if you look at, say, somebody with a wrist fracture, the periprosthetics fractures had a big increase, but wrist fractures, people coming in with ankle fractures, and a number of other different things, their risk is much lower. And I think partly it's the how major the surgery is, but probably how long they stay in hospital for. And I think the if you're in hospital longer, you're more likely to catch COVID. You've had a major procedure, you're more likely to be frail. And I think all of these play parts. I think it's multifactorial. A lot of it's common sense, but it is multifactorial.
Because that's a paper with almost over 1,100 cases. That's a large series they have.
Yeah, I think what will be interesting is, and I keep an eye out for it, is so the COVID Surge Collaborative at the end of August finished collecting a much larger data set, and I think they'll be able to do sub-analysis much better than the original paper. And I don't know if anybody's taking part in it, but COVID Surge Week has just finished. It's taking 4 individual weeks across October and looking at every single case that went through theatre, not just those that were COVID positive, and looking at patients who were treated in zones and not in zones and what procedures we're having. That'll be coming out probably in the new year, I would have thought. But that will be a much bigger piece of work and will inform us much better, I think.
Yes. Okay. Yes, Rajendra.
Can I ask, in the safe zone, in the green zone, in the restricted zone, what was the PPE protocol? Was it same everywhere, or was it?
So within the green zone, it is almost normal practice, with the exception of two differences. One is that we ask everybody, patients and staff, to wear a fluid-resistant mask all the time.
Okay.
And then the other one is that for within theatre, when our risk was down at 1 in 50,000, we were happy for normal headgear to be worn for any procedure, including AGPs. However, we didn't make that mandatory because we felt some members of staff, because of medical comorbidities, because of ethnic origin or whatever, may wish to wear it, and we weren't saying that you weren't allowed to wear it. You could wear it if you wanted to, but it wasn't mandatory. So those are the only 2 differences. Otherwise, normal practices, and it's amazing how that's changed efficiency. Efficiency is much better. We're extubating patients in recovery, not in theatre. The whole flow within theatre is back pretty much to normal. We're doing 4 joint lists and so on. It's easy to do in the green zone. And the nice thing is we've had a lot of staff off shielding, and they have been able to return to the green zone and work there instead of working in the amber and the COVID positive zones within the hospital. So it's got a number of staff back to work as well, which is good.
Mr. Johnson, can I ask one question? You are isolating patient for 14 days, right? So are you getting that RT-PCR done before taking them to the OT? And if at all you all are doing it, then within how many days or hours you are taking the patient in for the OT? So
I got you cut out a little bit in the middle. So it's up to 14 days beforehand. It's either recommended or insisted. And then 3 days beforehand within that, they do a drive-through test at the back end of our hospital, and they drive up, wind the window down and have their test performed and drive off.
Mr. Johnson, really do they follow 14 days isolation?
Who knows?
Yeah, it will be very difficult to practice this.
Yeah. So some of the judgment on this is, and it's round the recommend. So you may have, let's say, a diabetic having an ACL reconstruction. I would recommend to them that they isolate. In a 24-year-old, you might find that particularly challenging. I'm not too worried. You explain the risks to them. The COVID Surge Collaborative leaflet, patient leaflet's pretty good at explaining this. And then the choice is the patient. It's up to them. If, however, I get say a rheumatoid patient who's on steroids and methotrexate, I really would insist with them. And actually, most of them, I think they do. A lot of them had already been shielding anyway over the summer, and they just want to get their joint done because they're fed up. They will do all they can to make it safe.
Okay.
Okay, carry on.
Yeah, please carry on,
question, David. Good and bad part of it, in UK, most of them were really following that 14-day thing. And India, maybe they were not following that 14-day thing. So the resurgence or reinfection is to those loyalists who were hiding inside the home.
Yeah.
And in India, because they may be in a cluster developed herd immunity kind of a thing, So,
yeah, and I think there's a lot that this probably plays into what's going to happen in 6 months, a year, 2 years time. Is there's a lot we just simply don't understand about herd immunity, about vaccination. We just started at Stockport recruiting to the first greater Manchester recruitment to the vaccine, one of the vaccine trials, Novavax. And we've got 15,000 patients going into that. We're recruiting 700 of them. We won't know for ages what's going to happen longer term. We don't have a clue at the moment.
Absolutely. Yep.
Yes, Rajendra.
Yeah. During this waiting period for 14 days, say for fracture of intertrochanteric neck femur, where they put on sort of traction or the Watson-Jones sort of treatment?
So this is purely for the elective patients. The 14 days is for the elective patients. Okay. So we handle our emergency patients differently, but we'll still use a green zone. And this is where our medical director had a bit of trouble understanding the philosophy behind it. There's two things we're trying to achieve. One is to reduce the risks of a patient being positive at the time they have their operation. And it's quite nice to know whether they're positive or not. You may crack on and get on with their operation. Okay. So that's one risk, and that's where your 14 days and your testing beforehand comes in for your elective patients. For the emergency patients, we get a test done, and probably about 95%, we know the results of that test before they come to theatre. There are a few that we don't get test results back for. We do have a problem with capacity. But at least you know whether they're positive or not at the time of their operation. That helps determine what staff PPE you're using at the time of their operation more than anything else. For post-operatively, we're putting all the patients in the green zone. The moment you know a patient is negative, then you have reduced the population of negative patients' risk of being positive within them. We know the test isn't 100% sensitive, but if you know a patient is negative, then you can cohort them in the zone. So they go to the green zone in a different ward in the green zone. We've got 5 wards or 4 wards in the green zone. And for our trauma patients, they go to a different ward than the elective patients. That population has a reduced risk. So I wouldn't delay somebody going to theatre. They go to theatre. It's nice to know the results of their test, but we don't delay them for the 3 days, 14 days. We get a bit of assurance in that we retest at 6 days every single patient who's in hospital. That is the aim of that, is to try and filter out those who may have been negative in the first few days of an infection when they arrived on our doorstep. Now, for the elective patients, that shouldn't happen, because if you isolate for 14 days, very few, with a negative test, very few will be positive after that.
Okay. David, I know you are a knee surgeon, but my question is, with this 1.89 times risk factor, has the conservative management of fracture has increased in your setups?
A little bit, but not massively. So there's a separate project you keep an eye out for called Impact, which is run by the Scottish group, looking at all fracture neck of femurs. They've taken our national hip fracture database set and added to it some additional questions about how we've managed the patients, and they are working on their data at the moment. But at the time, we've looked back at our cases that presented. It was interesting with the hip fractures. In April, we had a 50% increase in hip fracture presentations, simply because we think patients decided that elderly folk decided that they would look after themselves. Leave me alone, I can look after myself. I want to isolate, and then they weren't able to manage and fell and came in with us. Now, a number came in with COVID, a number caught COVID with us. We took quite a number of patients to theatre with COVID, and there was no doubt the mortality risk was increased in that group. We did have a number of patients with COVID that we managed conservatively, but most of them were not because they were COVID positive, it was because they were simply not well enough to go to theatre. We felt giving them an anaesthetic would almost certainly kill them, and we felt that for those patients it would be not the right thing to bring them to theatre. I can't think of any where we managed them conservatively and then subsequently took them to theatre. I think most of those who we felt were unfit to go to theatre subsequently died. Okay, so I'll carry on then. So it's all very well looking at reducing the risk and a bit of theory, but how do you actually make this work in practice? So I'm going to look at 3 areas: infection prevention, waiting list management, staffing and safe zones, and actually creating safe zones. We've done the theory of the safe zones, which I think are a good thing. So we've got safe zones, we've got staffing to consider, we've got infection prevention to consider, and the waiting list. And what we're aiming for is this group here. You need all of these working together in order to make this happen. So for the safe zone, you may have a regional solution, safe hospitals, or you can adapt to local estate. And I'll give an example of what we did in a little bit. And that's combined with testing. If you're going to put somebody in a safe zone, you have to have some form of testing with or without isolation beforehand. You need to staff that zone. And if your staff are being pulled to go elsewhere, that is going to affect the capacity within the zone. So you can have as many beds in the zone as you want, but if you can't staff those beds, you're not going to get any capacity through. And you really do need to match the staffing to the bed capacity, especially if the surge comes back on again and you need those beds. The waiting list, there are regional solutions, which I'll come to in a minute, with local implementation. How you manage those patients, which ones do you do first, what do you do about those people waiting a long time is important. And then whatever you do, you need robust protocols to cover your infection prevention working within this. These two, the safe zone and the waiting list, are inextricably linked. How big your safe zone will determine what you can do on your waiting list. If you have a safe zone, you can deal with your waiting list. If you haven't got a safe zone, I think for elective surgery, you can't deal with your waiting list. So they are inextricably linked, but they are dependent on being able to staff it. If you cannot staff beds to do the work, you cannot deal with the waiting list. And the 3 put together are the most important links in actually getting capacity back. Important is the infection prevention, but that can be delivered in any scenario. So infection prevention, I've produced our protocols for theatre at our hospital. We've shared them across the city. We're all doing pretty much similar things. What's interesting actually is the mention about creating the IOA guidelines. Effectively the same happened with us, is that we were producing our own guidelines, which fell pretty much into the BOA and Public Health England guidelines, but we were producing them an awful lot earlier than were being produced in print. But it was quite nice to see when they were produced in print, what we were doing already fell pretty much in line with what was being recommended across the country. We've got protocols to cover how to use the safe zone, how to get in and out of it, and so on. Again, that's an issue for a separate talk. Screening of staff and patients. We've got difficulty with capacity and speed of getting results back, but that's getting much better. The one thing we're not doing at the moment is routine staff testing. We have done a couple of rounds of staff testing, but that, I think for the safe zone especially, will reduce risk of transmission. Pre-op self-isolation, as we've mentioned, and then operating practices, including PPE and so on. We know, as I've mentioned before, that theatre capacity is much better when you're working in the green zone. The other thing to bear in mind is we've discovered is that with our practice at the start of the pandemic, we think our infection rate went up for implanted procedures, fixations and so on, simply because of how we were operating our PPE, whether it was the masks with filters that blew out across the patient. We had headgear on, which we kept touching. We had we had X-ray staff in theatre for the whole case. We kept the bed in theatre for the case. And these things will inevitably have increased the risk of infection. So all these protocols, whatever they happen to be, your trust can be applied anywhere, and they are vital for success in reducing transmission. So what about the waiting list management? So for Greater Manchester, we'll come out the other way. Greater Manchester have looked at this and they feel cancer, endoscopy and ophthalmology are top of the list. And there's a mandate across the city to prioritise these cases. This is along with urgent cases within every speciality dependent on need. They have looked at transferring patients between hospitals, safe zone solutions, which I'll come to in a minute, higher volume centres and use of the independent sector hospitals, which has been working. Locally, what we do is determined very much by what we're told to do by Greater Manchester. One of our biggest problems we're finding is that as we've started to try and do the more routine cases, urgent cases come along and take the place of those routine cases. So on the urgent, the category 2 cases, which have to be done within a month, category 3 cases within 3 months, they keep appearing and obviously need to be dealt with because of clinical need. And the poor category 4 patients keep getting bumped further down the list. So they are going to get longer. There's going to be inequity. But I think this is a fact of life at the moment. What happens on the waiting list is also interesting. Sometimes you have to recategorize patients. A category 3 patient who has to be done within 3 months, if 4 months goes by, technically they should really become a category 2 or a category 1 patient. So there's a certain amount of automatic upgrading of patients from one category to another if they've waited longer than their time that they're supposed to have waited. And we have been reviewing all this to see if this is the patient remains on that state or whether they do need to be done more quickly. Say for a patient waiting for knee replacement, if they're losing bone, whether that needs to be brought forward to prevent needing a much more difficult procedure. Where they looked at the waiting list, they've done their PROM scores and all their hip and knee replacements about this time last year when they were put on the list, and then they haven't had their operation. So what they did was send questionnaires back out to them. And I think something like 30% of patients, whilst on the waiting list, have become worse, 50% stayed about the same, and about 20% actually got a bit better. Not all patients want an operation at the moment. A lot of them turned around and said, look, actually, can I wait? I feel my risks are high. I'm looking after an elderly relative. Can I leave it for the moment to have it done another time? And the other thing that we're discovering is that quite a lot of patients forget their reason for listing for surgery, have become unfit and deconditioned whilst they're on the waiting list. They've been shielding, they've waited at home, they haven't been exercising, their muscle mass has gone down, especially in the elderly, more frail, and they become unfit. They've not sought medical attention for the shortness of breath they've been getting or angina or whatever. So they're arriving in a less fit state to have these procedures performed. I think a revisit for patients on a good quality pre-op assessment, not basing it on one that was done months ago, is really important. And the other thing is that certainly for a lot of specialties, there was historical waiting list problems anyway. Thankfully at our trust, we were one of the better in the UK, and you'll see that in a minute. But some trusts were running very long waits coming into this, which has compounded the problem. So if you look at our wait, so pre-COVID, we had 2,900 patients waiting for something to happen. That included clinics and theatre lists and so on. We run on an 18-week performance to see how many patients, and we should be achieving more than 95% at this. And we were not far off one of the best in the UK for this. But in September, that had gone down to 60%. So a lot of our patients were waiting on the wire of the 18 weeks. Our breaches for 18 weeks have gone up. Traditionally, we've been very good in not having anybody waiting more than a year for treatment. That started to go up. And what's interesting, although the total waiting list hasn't gone up that much, most of them have ended up on the inpatient and day case waiting list. So a lot of the patients we're getting through now on the waits are actually going straight on the list. So we're seeing a higher listing rate than we were previously. A lot of patients we'd see and we'd discharge from the clinic. They didn't simply need any operative treatment at the moment, but actually now the patients we are seeing are needing to go onto the operating list. What have we got back to with the regards activity? There was a big push over the summer because we're one of the major centres for urology. Although our population in Stockport covers 330,000 patients, actually for urology, our unit covers a population of 1 million. And so there was a big push to get the urology cancers up and running, which we did at the end of May. And they're running at 104% lists, allocated theatre sessions to do that work. And most of that work is on catch-up. So their benign treatment is not going ahead at the moment, or a lot of it isn't. This is for catching up on cancer work. Maxillofacial, there's a lot there. But look at us, orthopaedics, only 46% of elective sessions have gone back on again in October compared to prior to COVID. So we had got back to nearly half capacity. We were mandated by the end of November to be up at 80%. I don't think there's any unit in the country that's capable of delivering that because of the second wave at the moment. But I don't think it was as a trust for the GM figures for all specialities. I think we were doing pretty well, operating a green zone on a much reduced theatre capacity overall, which I'll come to in a moment. Is that just us in Manchester or Stockport? No, it's the same across the whole of the UK. All the medical outpatient specialties are doing absolutely fine. They're getting back up to their capacity. The surgical specialties around about 50%, with their second worst performer is orthopaedics. And I'm sure you will find exactly the same problem when you're getting activity back running in India. But remember, although cancer clear is very important, if you look at Chloe Scott's work, 19% of hip patients and 12% of knee patients are in a state worse than death with regards to their pain and how they are functioning. And this is getting worse whilst they're waiting for their procedure. So it's not something to bat by and say, well, we'll sort it all out when the pandemic's over. We really do need to get back treating these patients. So that's the waiting list. There's a lot more that could be covered there, but I'll leave it there for that. Staffing is really, really important. It's probably the biggest problem. There's only so many staff in the system to go around. You can't create nurses overnight. There are only so many in the city. There's a lot of movement in the city, and there traditionally has been. People flip between trusts, but actually there isn't a big pool to pull from if we run into a problem. We've also got the additional problem running two services. We're running a safe zone service, and we're running a COVID positive or unknown zone as well. And certainly if you're running an isolated area in a hospital, you have to consider how you run these two areas. It's difficult. Even if you're running separate hospitals, that is also difficult to do. And so although there are lots of alternatives using independent sector, we've got our Nightingale hospitals, we've got a huge one up in the middle of Manchester. We're being told we can use it, you can have the beds, there you go, it's all set up. Oh, by the way, you have to bring your own staff. Well, we haven't got any staff to bring. And the same goes for the safe hospitals. Yep, we've got space, you come and operate here. Oh, by the way, bring your own staff and you'll have to cover your patients in the post-operative stage overnight. We simply don't have the staff to do that. Nursing staff, medical staff, and so on. It's very difficult. Probably the one that's worked best is the independent sector, where we've taken lists and we've done a lot of day case work there, which has been extremely useful for cancer diagnostics, and for the orthopaedic day case work, it is actually has put through quite a large number of patients. So in the second wave, the biggest risk is actually losing staff. We were already losing staff to nursing staff, ancillary staff to our COVID wards, which have increased. We've got about 150 COVID patients in our hospital at the moment. There's less loss of anaesthetists and anaesthetic staff to ICU at the moment, because this time around we have seen that although the admissions have gone up simply because the local population prevalence rate has gone up, admissions to ICU has gone down. So they're either people are coming in less sick, they're coming possibly a little bit earlier, and we've got a number of treatments which are coming out of the recovery trial, recovery RS trial, which seem to be making the disease they're getting less severe. So this time round, we seem to have less of a pressure on intensive care. What I would advise is you protect what you can. I would protect a safe zone if your bed capacity permits. I would put as much into that safe zone as you can. So like I said, a hip fracture comes in, you get them tested in the emergency department. Rather than putting them on an amber ward whilst you're waiting a test, you do a fast test, rapid test, 2-hour turnaround, and admit them straight away to the safe zone. You do all your urgent activity and cancer work in that. We do as much as we can, and we were already doing this actually, for wrist fractures, ankle fractures. They'll be seen in the emergency department, placed in a plaster, sent home. They get a COVID test when they get sent home, and our trauma nurses contact them to bring them back to the green zone 3 days later for a semi-urgent slot to have their surgery performed in a slightly safer manner rather than using our trauma beds. You've got to accept, whilst this is running, not much elective work may get done. But if you keep your zone open, then you've got the capacity to open it up further. If you close your zone, getting it back open again will be a nightmare. So for the regional safe zones, those are the trusts I mentioned. We've got some additional hospitals within those groups, and those are the places that are taking COVID patients and trauma and doing some safe zone work within them. They're shared hospitals, combined safe zone and non-safe zone. But we have a number of other places that it is possible to segregate them. So Rochdale and the Christie Hospital are doing cancer work as green zone sites. Bury can separate part of it off for orthopaedic elective, as can Trafford, and obviously Wrightington will be doing the same thing. But again, they're all suffering the same problem. So Wrightington lost a lot of their staff back to Wigan to staff the COVID ward. So there's a limit to what can be put through, but there is the capacity within the system to do a number of specialties on safe sites. But there are pressures trying to organise this. So there's a regional solution, but you can also create a safe zone within your hospital and put as much through it as you can. By having those patients screened beforehand, your incidence rate of COVID in that area will be much less, it will be much safer. So I'm just going to take you through what we did in our hospital. This is our main theatre complex. We've got a couple of small minor ops theatres elsewhere, but these are our main theatres. Those are our laminar flow theatres. Those are our standard flow theatres, and they're all on one floor. We've got 2 laser theatres, and the importance of these is you need one in the green, one in the safe zone and one outside the safe zone to deal with kidney stones. We've got a robotic theatre for the urology cancer work. The important thing is when you're setting up a safe zone, and we looked at this plan and thought, how can we create a safe area within this with the wards, with the entrance to get in? And you have to take a number of things into consideration, we discovered. A lot of this was discovered further down the line, but has actually been extremely useful. And the first thing we did was look at how the place was built, because often you've got breaks on the edge of where that place was built, which will tell you how to split the area up. So when I arrived at the Trust in 2001, that was the only theatre complex that we had. Not long after I arrived, we built this theatre complex, all laminar flow, as I mentioned before. Then this block went up, then this block went up. And those lines have effectively formed the boundaries for the various areas that we've chosen to create within it. You do need to take into account how to get up and down to theatre with the lifts, but we do have access further down the corridor with separate lifts that you can use for the COVID patients. Really important, and I didn't realise this when we started, you need to make sure you get the right number of changing rooms in each area. It is vital. I've never heard, often when you create these things, you deal with the big stuff and then forget that the poor staff are going to have to change in these areas, and how's that going to manage? And then we had to keep a laser theatre in each zone. So what we did was, that's the theatre floor here. We've got the ground zone, the entrance and the exit here. And then we've got a top floor with ward space, which you'll see in a minute. So at the beginning of May, we created a safe zone in the theatre complex. We created a ward within that complex in here. We had the theatres, and we started doing urology cancer cases. Patients came in from here, went up to here, as did the staff. They didn't interact with the rest of the hospital. We had a changing room, 1 male, 1 female within it. In July, we extended that zone to 6 theatres. We included all the wards on the top floor, which gave us 102 beds. We had an X-ray room in that area, so patients didn't leave to get post-op check X-rays. That gets done on the top floor. And again, entrance and exits separately from the rest of the hospital. And that's what we've been running pretty much since then. It's appreciated that our second wave may make the use of that top floor difficult. We may need more beds for COVID patients. So we have got a plan to retreat within our theatre complex, and we've actually turned our reception area into an 8-bedded ward here for use, so we can carry on with urgent cases as well as those cancer cases that we initially started with in June. And ultimately, and this is where a big flip comes, and this is where recovery comes with getting back capacity in the category 4 cases, back to opening the top floor, but we're going to flip the theatre floors. We're going to make this area here on the white area in the middle floor as the emergency cases for the COVID unknowns or COVID positives. And then we're going to have 11 theatres split between laminar flow and non-laminar flow for trying to get capacity back to the elective cases. So there's our plan. It's probably going to change again because it keeps doing so, but those are our plans on how to do it to get those zones working within a trust where you're dealing with both types of patients. So have we got it sorted? Well, as you know, our lockdown started yesterday and we almost got it sorted. We almost had that full capacity running until a couple of weeks ago. We feel we've got our infection prevention measures and SOPs are matured. There's a bit of tweaking going on all along, but actually, I don't think much is going to change with what we're doing on that front. We were about to start full capacity, but we're now back to doing cancer, but we're able to accommodate urgent cases only. So when we started back doing the more elective stuff, we only had 2 theatres, non-laminar flow. We've now got 6 theatres, although we can only staff 2 of them. We can choose whether we use the laminar flow, the non-laminar flow, whether it's urology, orthopaedics or whatever, we have that choice. We had resolved our staffing issues. We'd even managed to recruit to the empty posts, but we've lost a lot of staff to the COVID wards, which has reduced the number of theatres we can run. But we have got the safe zone fully open, and our plan is to keep it as full as possible, including the trauma patients in their own area, so that we can run them through theatre for the safety reasons, for the reduced risk of transmission between patients as I've been through before. So, any questions at this stage?
You said that it's better to create a safe zone, but almost 70 to 80% of our patients are asymptomatic. How to keep the safe zone safe? Because they will be contaminated by this asymptomatic patients anytime.
Okay, so if you do a COVID test on those patients, then that is around about 70% sensitivity. I think the newer tests are getting more sensitive. Then your risk of that patient, a patient who has no symptoms being positive, goes down. You can increase that. If you wanted to delay it, there's a couple of things you can do. If you can isolate patients, if you say run side wards or that sort of thing, you could isolate them. Difficult, especially with staff going backwards and forwards. The other thing you can do is repeat the test. So if you do 2 tests, your sensitivity goes up. That's covered in the BMJ article I mentioned earlier, is you can actually do 1 test and then repeat the test the following day. And if you get 2 negative tests, the chances of that patient being positive are really quite slim. So the one important thing is when you run a safe zone, it's not a COVID-free zone. You'll hear COVID-free hospitals, COVID-free zones. There is no such thing. You will get patients in those zones. It's just a matter of what you can do to actually reduce the prevalence rate of COVID in those areas to make it what you deem to be in your hospital safe to work more normal practices. You're never going to get rid of it completely. And the starting point, like I said, is knowing what your local prevalence rate is. So if you've got a really high local prevalence rate, running a green zone is still worth it, but you may feel that running normal elective services isn't appropriate. As the local prevalence rate falls, the prevalence rate in your safe zone will plummet. And so let's say go down from 1 in 2,500, which it will be in our trust at the moment, back down to 1 in 50,000, which is what we had in August. And you say, okay, that's fine. I'm happy to accept that. You need to know your local prevalence rate. And if it's very high locally, you may say, actually, doing revision knee replacements in patients who don't need it because of urgency is not a good idea. But when the rate falls, it may become a good idea.
Okay. Yes, Rajendra.
Yeah. Initially, in orthopedic surgeries, there were great concern about aerosol being disseminated in the operation room with reaming and with saw working, etc. So, is that tested with virological test, and is it true?
So there's two bits to this, or 3 parts to this, really. One is, what's the chance of there being viral particles in reamings? My understanding is that's relatively low. It's nothing like using a burr for an ENT procedure on the mastoid process or something like that, or the mastoid air sinuses, which is completely different. So if you use a burr on the mastoid air cells, that is considered an air generating procedure. But if you use a burr in the hand, I think the risk is pretty low of having viral particles there in the first place. Second thing is around the management of it. What does it actually create? The burrs, the reamings, the drilling, the saw, and all the rest of it, diathermy, they don't create aerosols. They create particulate matter. And they fall away very quickly, especially where you've got laminar flow. It just gets driven straight down for the most part. One thing I'm particularly keen on, there's a really good video of it, is what happens with the operating lights. You need to make sure that your laminar flow is working. So although you may have a laminar flow tent, if you put a light, park it straight above the area you're operating on, you will destroy that laminar flow. Going back 4 years now, I've stopped using operating lights for joint replacements and a lot of surgery. The few procedures I do use it for where I can't see, so unis and ACL reconstruction, but actually almost all operating I do now is without an operating light, for the simple reason it creates eddy currents underneath that light, which destroys the laminar flow. And certainly for hip fractures, we stop using lights. All of us stop using lights, which will stop those particulate matter being taken away by the laminar flow. So that's one thing to consider there. And then the final thing is the screening. If you know there's a risk of your patient in your green zone at a particular time of, say, only being 1 in 10,000 chance of being positive, again, with those two things and that low risk, the risks are pretty low. So I now, if I know a patient is negative, will wear an ordinary fluid guard mask for, say, a hip fracture, for a knee replacement, or so on. If I perceive there is a higher risk, yes, I would use a FFP3 mask, an appropriate headgear with that.
Thank you.
Sandeep?
Yeah, Dr. Johnson, I just want to ask, is there any protocol which is followed for the attendance of the patient? Because in a country like India, the patients always come with 2 or 3 attendants. So even if you, so is there any set protocol for that? Because we are testing the patient, but what about the attendants?
Okay, so very important that. So I mean, I remember when I went to the CMC in Vellore, entire families would turn up and cook for the patients around the bedside and so on. And I fully get that. So for our hospital, at the time of the start of the pandemic, no visitors, none. Apart from a woman in labour or going for a cesarean section, their partner could come with them. And for paediatrics, one parent can come with them. And for now, for our elective paediatrics, we test both the patient and the parent that's going to come with them, and they isolate for 3 days beforehand. We're not asking them to do 14 days. And that's very strict. That's been since April. It's been really hard, and that's probably been hardest for the COVID patients who were only allowed relatives when it was felt that they were dying, and a relative would be allowed to come and see them to say goodbye. And that has been really, really hard, but I think has actually probably helped in preventing transmission of infection.
I think that is quite important. The second question which I would like to ask is that how often are you testing your doctors, those who are operating? Is there again a protocol, or just?
There's an ideal and there's what's happening. So the ideal is testing on a frequent basis. One of our local private hospitals, the Spire Group, they're testing any staff that go to their hospitals in the whole country. They've bought out, they've created their own lab facilities and testing their staff every 10 days. That is the only group I know. There's one hospital in our region that's able to test their staff on a similar frequency. I think they're every 2 weeks at the moment. There simply isn't enough testing capacity to do it, and we can't get the test back quick enough to do it. So what we're doing at the moment is, if there is any perceived staff outbreak risk, then the entire staff in that area are tested. If there's a wider area, which we had in, when was that? That was around about June, July time, the whole hospital was tested. Very shortly, I hope, every member of staff will be tested across the whole of Greater Manchester, but it is pure capacity, the number of tests required. If you wanted to test all the employees in the NHS on a weekly basis, that's 1 million tests a week, and the country is struggling. Their goal is to deliver 1 million tests a day. I think they're around about 500,000. That's for everybody in the whole country.
And what is the quarantine protocol which is going on? The doctors or the staff, those who are working in a COVID area, I'm not talking about the green zone. So,
so if you work in a COVID area, then you should stay in that area. You shouldn't be moving about. There will be necessarily some movement of staff from one to another. So one of our big things is that you start clean and go to the dirty area. So if let's say you're a physio and you may need to visit the safe area and the COVID area, then you would start in the safe area, move to the COVID area, and then you go home at the end of that shift, at the end of that day. You wear the appropriate PPE, and I think that is really important. I think that does make a difference. And the reason I say that is that our area that had the highest risk of getting COVID, which was intensive care in the in April, May time, actually was the lowest area of staff infection rate. So if you wear the PPE properly, your risk of infection is very low. And I say our ICU staff had a very low infection rate compared to general wards. So if somebody becomes positive, then obviously they have to go and isolate. If they've been in contact with somebody who's positive, they also have to isolate as well.
Okay. I think that clarifies the point that the mask and the PPE is very important while you are working in a COVID area. And we have also seen this, the same observation which you are telling, that the doctors, those who are working in COVID, are the least people, those who are coming positive. And in the other areas, the other people are getting more because they are more casual, they are more non-serious, and that is the reason that this is becoming increasing trend. Thank you. Thank you.
David, there is a question from Dr. Rajesh Daria. Is it mandatory for elective procedure to have prior COVID-19 test, but it is not easy for emergency and routine minor procedure? So how to proceed?
So elective procedures, everybody has to have one. If you don't have a test, you don't come in. If you are for the trauma, we try very hard to test every single patient before they go to theatre. Every patient will have been tested before to go to theatre. Depending on capacity on that particular day and the admissions to our hospital will dictate whether the result is available when they go to theatre. And it's not infrequent for a patient to come to theatre having had a test, we don't know the result, but whilst they're in theatre, we find out that they're negative and so on. We've had very few arrive in theatre halfway through the procedure, find out they're positive. That actually is uncommon to happen.
Okay. Yes, Rajendra?
So essentially those tests would be RT-PCR and not the COVID antigens?
Yeah.
But RT-PCR test is also many a time it will be negative. How to manage those patients who are negative RT-PCR? Because again, they might be asymptomatic COVID positive patients.
Yep. So again, it's just that it's plain straight numbers. It's down to that 70%. So whether that patient in front of you is positive or not is dependent on, number one, a negative test and the prevalence rate in your community at that particular time. So what you do thereafter is depends on what number you come out with. If it's 1 in 1,000, 1 in 2,500 or whatever, will vary that. And the aim is just to try and reduce the risk. It's not going to get rid of it completely. Yes, the test isn't foolproof, but it's the best we've got that can be done quickly and will reduce, but not necessarily get rid of the risk totally.
Are we looking at a world when few years back we decided that treat every patient we put under our knives as HIV positive, and all due precautions? So are we looking at a world like that in future?
I don't know. I don't think so. And I think that would be, if we did, that would do a disservice to our patients. Like I said before, I think the use of the PPE has definitely increased the infection risk. We weren't doing any knee replacements then. We weren't doing any routine hip replacements. at our trust, we've got probably one of the better revision rates across the UK, because we're absolutely fanatical about reduction of infection prevention in those patients. And looking at how we practice at the first stage of COVID, I'm sure our rates would rocket if we tried to practice that way. I think what we do is we isolate, we test the patients, then aim to run normal practices. I think it would be a bad thing for patients if we said, right, fine, every patient's positive, we'll treat them as such.
Sure.
I think,
David,
David, you should let David finish his talk, because we are already overshot by 10 minutes. So let him finish, then we can have a brief, short discussion at the end. Please.
So not much more to go. So the next bit is just a few thoughts of mine as we've gone along with this, of things I've learned from my own part, doing some stuff that I've never done before, doing some organising and protocol writing that I've never done before. And it has been interesting, I have to say. So number one, it's not over yet. There are going to be more changes. Plan any changes well ahead of national guidance. Chances are, if you decide to do something that makes sense clinically and common sense, it probably will be the right thing to do. You need changes to happen quickly. If the situation worsens, change quickly to adapt to that. We're very good at that. What we're not very good at is changing quickly when the situation improves, making the most of a lull or a dip between spikes. The moment it starts to get better, get back onto that plan that you made weeks before to get your elective activity going. Get on and implement it as soon as you can. There will always be nervousness about doing that, but just get on with it. And I think we're going to be working differently for a number of years to come. It will go, something else will come along, and we mustn't forget the lessons we've learned from this pandemic, because there will be another one in the future at some point. For estates, understand your estate and work with it. Build and knock down as little as possible. And like I said before, staff happiness is really important. One of the things that seems to press all the wrong buttons is where the changing rooms go. So often a good place to start when looking at your estate is where the changing rooms are. Once you've created a safe zone, defend it. It improves the outcomes. It reduces hospital-acquired COVID. And it improves efficiency as well. The staffing, try and keep your staff in the roles they're doing. Care is safer, staff morale is better. It may be unavoidable to move staff to doing things that they're not used to doing, but you do need to be aware of burnout. You can't rob Peter to pay Paul. If you move staff from one place to another, then you lose something, having gained something else. The other thing is, staff don't mind big changes. Rather than make lots of little changes, keep them big, make them infrequent, make them very clear, and write it all down, get them in SOPs, quick reference guides or whatever, so staff know what's going on. Communication is vital. Infection prevention, you need to address the nervousness of management about doing some of these things. The COVID-19 protocols are pretty easy. There's lots out there. Theatre needs to be more efficient. Safe zones are better to run. The non-theatre processes are actually the biggest pressures. The waiting list management, the pre-op assessment, those sorts of things are the difficult bits. For the waiting list, lead times are greater. You need to manage everything way ahead of what you would normally do. Don't forget pre-op assessment, testing, and the plans are going to change. So my list next week has gone out the window, but I do have 2 urgent cases on it. So one of them's been moved to a different list in a different hospital, and the other one we're just working on at the moment. There is danger within a city of inequity of treatment, and that's going to be compounded during a second wave. So I think really to restart your elective activity, these are your starting points. You've got to think about all these things. And they've got to all be working together in order to get the restart going. So that is a brief hurtle through. I know it's taken a bit of time. There's lots we could talk about, but that's us at Stockport from one of my favourite Lowry pictures. If there are any questions about my talk, I'll happily take them.
David, it's about the second wave. So in England, what are you facing? Are these the patients who are not earlier infected and getting infected now? Or are these, patients who have faded out their antibodies? As Nuffield data says, the antibodies will be active for 90 days. And half of them will then lose it end of 90 days. So what are these patients now you're facing?
So my understanding that is the patients we're getting now are quite different to the first ones. The first ones that came, I think there were probably a lot more than we ever knew about, because testing didn't happen until sort of, it didn't properly come in until about May time. So we have no idea how many patients were infected in the first wave. We don't know if that first wave was bigger than the second wave. What we know is that the mortality rate across the country was much higher in the first wave than the second wave so far. Now, that's either because we didn't know how many people were infected first time round, and I suspect that's part of the case, but also who we're getting is slightly different this time. Whether the virus has changed or whether different people are getting infected have changed this time, I don't know. I don't think there are that many coming in with a second infection. I think if there are, I bet you anything, they didn't know they had the first infection, then they're getting the second infection where there may be some residual antibodies, so their infection isn't as severe. But what we're getting is we're getting a large number of people getting it. We're getting a large number of people coming to hospital with it. Liverpool's particularly badly affected. Manchester's following on. Everywhere else is going to follow on. It'll happen. There's no doubt about that. The patients we're getting in are less sick. So we're managing more of them on the wards. Our intensive care unit, which has had 28-30 on it in the first wave, at the moment, I think only has 7 patients on at the moment, whereas our hospital is a lot fuller than it was last time. The other thing that might be happening is I'm sure schools and universities have played a part in it. So we're getting younger, fitter patients getting COVID at the moment. So although the numbers have gone up, the effect on them is not as severe. And this may play a part in the herd immunity that's yet to come. And, time will tell on that one, whether that is a problem or not. So we're getting bigger numbers in, the wards are getting full, the staff are getting pulled from there, but they're not as sick as they were first time round.
Okay, thank you.
Yes, Rajendra.
Yeah. When the RT-PCR is positive in this patient, do we take help of corroborative tests like D-dimer, CRP, or CT chest? Are they being undertaken?
No. So the test is to see if they're positive. We've got a number of patients you are completely sure they've got COVID and they keep coming up with negative tests. But if a test is positive, any further testing is very simple. You do a test that's required clinically. If the test isn't going to change how you manage the patients, don't do the test. So knowing whether a patient's positive or not will determine where you go and to a degree what management you're going to offer them. But actually any test beyond that, whether you do a CT of the chest or whether you do other blood tests or whatever, that's dependent on to how sick the patient is and what treatment they need for their condition.
Yes, Sandeep.
Yeah. Dr. David, is there any, if a orthopedic symptomatic patient, although RT-PCR negative, comes, then how do you manage such a case? Do you keep them in a green zone? Do you keep them in a separate isolation zone? How do you manage those cases?
So if you clinically feel somebody has COVID, I would keep them in our amber zone. So we have an area which is the acute surgical unit where patients come in, say they get a 48-hour test. There's no rush because they're not going to go to theatre. Often the surgeons will wait. We will often keep them in that sort of area.
So do you repeat their RT-PCR?
Repeat the test.
After how many days? 48 hours, 3 days?
Yes, so the standard is 6 days, but if clinically you feel that they need a repeat test, you can do it sooner than that. So you usually do it a day or two afterwards, yeah.
So do you get their CT done? Suppose he's an RT-PCR negative, although he is symptomatic and you think that it is a COVID positive. So is there any role of CT scan in such patients?
No, so that initially there was a big push to everybody must get a CT scan. And that overwhelmed the radiology department and actually probably had a lot of radiation exposure that wasn't necessary. So if a CT scan is clinically indicated, it will get done. So if somebody is really quite sick with their chest, what the decision that may get made is it will decide whether they get the oxygen therapy and they go into the recovery trial or whether they get purely antibiotics to treat chest infection, which they may equally have.
Otherwise, not for screening.
Not for screening.
I think there was a lot of debate earlier. Now this has been clear. There were a few papers, although the radiologists never said that it should be done, but as an orthopedic surgeon, I read a few papers in early April and May, and they suggested that CT scan, the 1 or 2 papers from China also, they said that it is a very helpful modality. And the trend started that if the patient is RT-PCR negative and asymptomatic, people were going for CT. They are taking as a screening tool. So I think from this platform, it has to be very clearly told to everyone that CT scan is not the screening modality for these COVID patients.
And that's the rule across the whole of Greater Manchester for all specialities. CT should not be used for screening for COVID.
And as you rightly said, the one is the radiation, and the second is that you are contaminating all of the radiology setup if it comes out to be a positive. And most of the hospitals are not having 2 or 3 CT scans. So they might having a facility of only a 1 CT machine. So so just to prevent the spread of the infection, that is again important. The second question which I would like to ask is there any role of HEPA filters in the operation theaters, portable HEPA filters? Somebody, if they are not having a laminar flow or something, so can they use a portable HEPA filters?
That I don't know. It would make sense. The 2 bits to think about within the theatre are that the most important bit is that you have a high volume air change rate. So our theatres run at about 25 to 30 air changes an hour. That is sufficient for most procedures. Your laminar flow will give you additional level of benefit in reducing infection in your patient, as we all know from work from years ago, which has the filters within it. Whether taking a standard flow theatre and putting a HEPA filter within it, I don't honestly know the answer to that one. I'm sure there are people who know a lot more about airflow and what have you could answer that one. And there may be some in the documents out of Port and Down, actually. There is a Theatre Ventilation Association that you can search for that have produced a number of documents which are extremely useful, and videos as to how airflow works. The important bits are, if you've got a positive patient, is you doff in a negative pressure area, aside from the theatre. That is important as well. I suspect having a HEPA filter within the theatre probably isn't as important, because by the time you'll probably find for most things that are created in an orthopaedic operating theatre will have hit the floor by the time it gets to the filter.
There were a few suggestions in some of the papers which I read, that you can use an exhaust fan at the level of the floor of your operation theatres, and that can create a little bit of a negative pressure system, and that might help in this COVID situation. But I'm not sure whether it has any role or not.
To be honest, from what's come out from various places, I would probably not recommend that. Mucking about with your airflow probably will cause more harm than good, I suspect. You need to have somebody, and the interesting thing is we had a ventilation engineer from Port and Down come to visit as an advising engineer when we first started. And it turns out that although our theatres are pretty similar, with the biggest difference between laminar and non-laminar flow, actually our laminar flow theatres, because of those 4 different blocks we've had built, each of our laminar flow theatres ventilate differently from each other, even in our one building.
And are you all planning for an outpatient arthroplasty setup, which I think is again it's coming up, and few of the centers I would like to name are All India Institute of Medical Sciences. They have started doing, and they did a case in which they brought the patient of a total hip replacement on the day of surgery, and then they operated and discharged the same day. So are you all planning to do such a thing in your setup? Or?
Yeah, so you will hear about those, and we've got one centre in the north of the city who does run day case joint replacement surgery. It is for a very small group of patients, very defined, who are capable of doing it, and that it's great for them. It's great. What we've worked at our hospital very much is why don't we apply the same rules for everybody? I don't think we should be accelerating treatment through for one group of people and not another. What we should be doing is actually trying to give enhanced recovery as best possible for every single patient. By doing that, a few will go home on the same day. Quite a lot will go home on day 1. But even those that would normally have stayed 5 days may go home in 3 days. That's benefited them as well. the shorter you're in hospital, the better. I think every patient should benefit from an enhanced recovery program. If we can get a number down to a day, fantastic, but it's not going to be everybody.
Thank you so much.
Yeah, Rajendra.
Yeah. I would like to just know, how has your outdoor patient management, that is our OPDs, changed? Is it less number of patients with any airflow ventilation changes or the airstream changes, something like that?
So airflow, no difference at all. We're normally then standard rooms, so they run at about 6 changes an hour. PPE is important there, distancing is important. So that's the biggest effect's been on the waiting room. So, and again, it comes back to a clinic I will never forget in the CMC in Vellore, which was an upper limb clinic, where I think we saw something like 250 patients in the afternoon, and they all arrived at 2 o'clock. So that's gone out of the window. So what we're doing at the moment is as much by telephone or video appointments as we can. We're using NHS Anywhere for that. So that's working really well. But for the first patient appointments, certainly within lower limb surgery, we're finding that lots is missed. So each week I probably see at least one patient sent up with knee pain who were diagnosed as having knee arthritis based on a telephone appointment in the summer, possibly with an x-ray, who actually turns out to have hip arthritis. So you do need to examine these patients. So a lot of our first appointments are as face-to-face, interspersed with the telephone appointments, which then helps with the distancing in the waiting room. And then a lot more of these patients I'm now sending off for scans, and I'll do their follow-up on NHS Anywhere, where you can share the scan reports with them. You can show them, you can share the screen and show them the scan pictures and so on at that time.
Okay. Thank you.
Shiva, can I ask a question to your friend Shashi?
Yes.
It's been quite for some time, Shashi.
It's unusual that.
I'm doing some emails.
What are your quick tips for anesthesia in orthopedics? Any suggestions that you would want to give?
We're very fortunate to have Professor Johnson with us in Stepping Hill, because he and my colleague Matt Jackson, who's IC consultant, and the team, they work together very in a very good way in terms of getting the things ready for us. So I didn't have to bother too much about it. In terms of anesthetics, is one is that teamwork is key, communication is key, because as much as we clinicians are, we do have trauma coordinators, people who are taking the patient right at the emergency medicine department. The key thing is, if you want to operate on somebody soon, to think about getting that COVID test done. So there are different variety of tests, which we talk about, red and the green. Red, which is usually we get results within 2 to 4 hours, and be able to get that information. And be prepared to be flexible, because delaying a patient with a fractured neck of femur surgery will increase our mortality by about 15-20% every day. So be prepared that we do it while we're waiting for the result, and making sure that appropriate precautions are taken, not just for you, for the whole team. If you get your teamwork ready, well organized, everybody using appropriate PPE, making sure you have the team outside to help you coordinate this, things will be better. I will tell you why, because if you look at the whole world, especially in the United Kingdom, the mortality among the medical staffing, especially those working in intensive care and in anesthesia and theater, is low, because we do have a very big database. That is down, it is not just down to finding the finer details about what you're doing, it's also down to the teamwork, how we gel together, how we understand each other, how we work together to make sure we take appropriate precautions. Not only you're looking after yourself, you're also looking after your staff, making sure they are.
At the head end, you are the ringmaster, is it, Shashi?
No, no, you know, in NHS, this is a fantastic way. I do teach leadership. There's something known as a dynamic leadership. Sometimes you become a leader. For example, I'll give an example. If David is doing a revision hip or a revision knee, it mainly is a revision knee. If it's a revision knee, I want David to concentrate on what he is doing in the revision knee. And during that time, if something were to happen to the patient, I am then the leader. But in effect, if it comes to something to do with what David is good at doing it, suddenly I become a team member. I work with what David wants me to do. For example, in terms of dealing with sepsis, some of the things it is. So that's important because it's important that we're all leaders and we're all team members. And if you can, recognize that and work together, then we're all a winner. Other thing is that one of the other things which might have helped in theaters and anesthetics is the don't stay in that area for a longer period of time. So for example, somebody who's in a patient with a COVID positive in acute medicine is always been there. There's constantly nurses going there, the physicians going there. They're far more risk of getting COVID than me and Professor Johnson, because in theater, we are already screening them. We are already geared with protecting them. We are working in a theater where we got laminar flow theaters. We are far more trained in terms of dealing with, and the patient then leave the operating theater, go back to the ward. Similarly, in intensive care, there's a lot more preparations happen. And many times the patients who are in intensive care, especially on the ventilated side, they are intubated, ventilated. There's nothing coming out of the patient. Whereas a patient who's open, coughing, and always there, they have far more risk of generating aerosols in terms of increasing the risk of infection. It's important to understand these things.
I think one thing within theatre that became very evident is that actually the risk of catching COVID from an AGP is very, very low. You're far more likely to pick it up off a surface as you're handling stuff if you don't clean it down properly afterwards than anything else. That's probably the biggest risk actually in theatre is contact.
If you are training your juniors members of staff, this is important that we spend a lot of time doing some simulation sessions. We also spend a lot of time thinking about what is the things we need to do in terms of doffing and donning. People will forget it. And it's very important to wash the hands, make sure the surfaces. So for example, the moment you come out of theater, you will then go and touch a computer. So you need to make sure that surfaces are cleaned. In theater, David very rightfully did, where are you going to doff? We need to make sure that our doffing area is not exactly in the theater where we might be able to contaminate. So it's a lot of things. You also need to invest in the team which is going to clean theaters. So when we had the situation in March, we virtually had teams, people who work in theater, then we have team who are working outside to help. And we also have a cleaning team. So they would come and make sure everything is cleaned appropriately. So many of these things that is taken care of, then we are a winner.
Yes, Rajendra.
Is there any use or increasing resurgence towards ultraviolet rays used towards COVID protection, say in wards or after the patient discharge in the rooms?
Is that, sorry, ultraviolet, you say?
Yeah.
Not to my knowledge, no. I've heard mention of it, but there's certainly nothing coming into practice that I know of.
When do you do elective surgery once the patient becomes COVID positive? So when you plan him next?
So they've been positive. So they would do the standard 14. I think it's 10 days actually, but they would probably go for 14 days, and then it's down to a clinical decision as to whether they were symptomatic or not. So if they were asymptomatic, then there's less of a worry. If they're symptomatic, clearly you've got to wait until they're well again. There's quite a lot we don't know about this, which is where the COVID Surge Week will probably answer this, because there will be quite a lot of patients who have had COVID who were symptomatic, who are now coming for elective procedures, and we will be seeing how they're getting on. Personally, if I know a patient has been positive, and I've done a couple, I did one on an ACL reconstruction in July on someone who'd had COVID and had been quite symptomatic with it, I treated it as I would do with a chest infection and wait 6 weeks.
Okay.
Shiva, can I ask a
Yes,
general
sir.
question?
Yeah.
So, what is the most preferred mask by orthopedic surgeon? Is it N95 or those 3M masks with filters?
Very simple. It's whatever you can get your hands on.
Okay. Okay.
Personally, if I was doing elective procedures, and we are looking at this not from COVID point of view, but from a general infection point of view, is use of the ventilated hoods, the strike hoods or whatever, the wee ones. The only downside with those is that we didn't use those at the height of the pandemic because they don't actually filter out viral loads. They stop the patient getting infected. They stop your contact. The one thing it does do is suck a pile of air in from the laminar flow tent and shove it right against your face. So there was a suggestion, and some people have done this, is they've worn an FFP3 mask inside one of those. There are other ones which are the complete hood ones, which are designed as a company down south in the UK who's making them, but they're not sterile. So personally, if I'm doing an elective case that's been screened, I wear a normal surgical mask with a fluid guard on it. If it's a high-risk case with regards to something like Hep C or something like that, I'll wear Kevlar gloves underneath ordinary gloves, and I'll use the striker hood. If it's a known positive COVID patient, I'll wear whichever fit-tested mask I can get my hands on.
I think, okay, I think there are not many questions. Thank you, Professor David. That was a wonderful interaction we had. Since all of us have restarted working now, it was really refreshing to all the points you have said. Though we have been following, now we have some proof also behind that, and some of the data you have shown, your own experience that has really helped to gain much more insight into the COVID, definitely. Luckily, we were behind all the European countries. So we had your data made available ready when we had to face the battle. So that's the advantage India had because of the initial lockdown, which was brought in at the right time. And I take this COVID as a positive thing because in India, the health sector, 80 to 90% of the health sector is catered by the private people, and only about 10 to 20% of the people who approach the government sector. But because of this COVID, the infrastructure in all the government setup has tremendously increased, and that is going to help a lot to the people in the long run. So government has taken this as a on a serious note, and it is spending. Unfortunately, our GDP spending on health care was very, very less, which was less than 1.5%. Now with this, probably we might go even beyond the Sweden, which is at around 10%. Probably this year, our Indian GDP spend on health care will be much more higher. So we have learned really quite a lot, and because of this COVID itself, we have this opportunity to interact on this webinar. Probably I would not have met you if this COVID was not there. So these are some of the positive things we had to take from this disease and learn a lot. And this is going to help a lot in future also. As you said rightly, in CMC Vellore, you used to see 250 patients waiting in a room. So probably this disease will teach us that social distancing is also required, and it's making some differences in our social life in the long run. So thanks a lot for interacting with all of us so excellently. I know that we have overshot by almost 40 minutes and it's your lunch time. So I don't want to take much time. I would also like to thank Shashidhar, Dr. M.K. Shashidhar, my classmate, who was instrumental in bringing you and getting in contact of you so that I could interact with you. Thank you, Shashidhar, for that. And also thanks for giving your views as a leader, not as an anesthetist. As a part of a leader of the team from the head end, you could give your perspective toward the COVID. I would also like to thank Dr. Atul Patil, Dr. Shushruth Babulkar, Dr. R.M. Chandak, Dr. Sandeep Kumar for their interaction. Last but not the least, I would also like to thank Dr. R.C. Meena, who was here for the inaugural initial few minutes, but he had to leave because of his prior commitments. I thank all of you. Thank you, Dr. Ashok Sham. Over to you for closing remarks and close.
Thank you very much, sir. I think this was a very, very interesting and eye-opening session. So it will really help us in coming days to